Welcome everyone to the first of a series of 7 webinars aimed at admin and reception teams. The first one being awareness starts at the front desk. I'm joined by my two glamorous assistants today. They are Vicky Wright and Pam Kay. I'll do some introductions. I'm Tamsin Hogben. I'm a practice manager at Burgess Road Surgery, and I've been here for 18 years now. But I also work 1 day a week for Wessex Cancer Alliance as their practice manager advisor. I have my colleague Vicky, who is the non-clinical primary care lead for prevention and early diagnosis at Wessex Cancer Alliance, and Pam Kay, who's a primary care facilitator for Right by You. We'll be leading you through this first webinar. This is just a reminder of the 7 webinars that are coming up over between now and April next year. Today being the first one. They're all on a Wednesday and all 12 to 1 apart from one. So the next one after this is red flags and when to escalate, which is on the 23rd of September. They're all available to sign up to now through Wessex Cancer Alliance, through the Cancer Academy. There's a link on here. I will be sending these slides out afterwards as well. Okay, a quick run through of today's agenda. We're going to go through the role of admin reception teams in prevention and early diagnosis, some cancer prevalence and success stories, some going through the national screening programmes and other screening methods, some common barriers and misconceptions, people that can help in your practice, and other sources of help, information and advice. Yes, Shelley, the recording has started. I started it just before. Perfect. Okay, moving on. Now, the role of admin reception teams in cancer awareness is huge, I think, massive. We are basically the front door to primary care. Reception staff are often the first people patients speak to when they have concerns. They help people access appointments promptly. Their communication can encourage patients to seek help rather than any delay. They create the first impression of the practice, influencing whether patients feel comfortable in discussing any worrying symptoms that they may have. Patients may delay seeking medical advice because they're embarrassed about symptoms. They think their symptoms aren't serious. They're worrying about wasting their GP's time and obviously fear of a cancer diagnosis. Reception teams, admin teams can play a huge part in increasing participation in cancer screening programs. They can identify barriers to care. So receptionists, and you'll know this amongst your teams, they often notice when patients are repeatedly cancelling appointments. They struggle with English, they have hearing or communication difficulties, they can appear distressed, or just something feels a little bit off. Admin reception teams can effectively signpost, so they can encourage patients with concerning symptoms to seek medical advice promptly. They can book them into urgent appointments where appropriate. They can understand the practice escalation procedures for any potential red flag symptoms and know when to involve a clinician immediately. Admin teams, they kind of are essentially making sure people don't fall through the cracks. So they can arrange, as I said before, urgent appointments, book follow-up reviews, ensure referrals are sent promptly. They can track referrals, especially to rate referrals, monitor outstanding hospital responses, contact patients who need repeat investigations, to name but a few. Other things that they can do is maintain accurate patient records, such as addresses, telephone numbers, ethnicity, and this basically means that screening invitations can reach patients, hospital appointments can be received properly, referral letters are delivered, and important communications aren't missed. One of the most important things as well is building trust. Patients often tell receptionists things that they haven't told anyone else. So a kind response can reduce anxiety, encourage disclosure, improve attendance, increase confidence in seeking help, and compassionate communication generally does save lives. And last but by no means least, supporting patients through their cancer journey, if indeed they are diagnosed. You guys often help patients navigate appointments, coordinate information, arrange sick notes, and support carers. So not a lot really when you think about it. Okay, moving on now, my colleague Vicky is going to discuss a little bit about cancer prevalence.
Thanks, Tamsin. If you're happy to move on to the next slide, I just thought it'd be useful to share a few stats just to kind of highlight how massive this thing is that we're talking about today, cancer in the UK, why it is really important that we're having this conversation today. So just to give you a kind of sense of the scale of the issue, in the UK, there are around 3.5 million people living with cancer. So, and in terms of new diagnoses, that's around 400,000 every year, which equates to around 1,100 every day. I think one of the shocking statistics that I heard a few years ago, and I still can't quite get my head around it, is that 1 in 2 people will be diagnosed with cancer in their lifetime. So it is very real that everyone will have, either it may happen to them or a very close person to them in their lifetime. So it is really important that we're having this conversation. But one of the things that is worth mentioning, and we're going to talk a little bit about this later on, is that actually around 38% of those cancers could be or are potentially preventable. So when you look at that percentage with the amount of cancers, newly diagnosed cancers, you can see that potentially we could have a real impact if we do have a focus on prevention. So like I said, we'll talk a little bit about that later. But when we're talking about the issue as well, we do have to reflect on the number of cancer deaths as well each year. So around 170,000 cancer deaths each year. So we're doing lots of work as a Cancer Alliance into looking at how we can reduce the number of cancer deaths. And one of the ways that we can do that is through early diagnosis. So I quite like this infographic because it sort of tells you it really sort of shows you the importance of early diagnosis by looking at the stages. So if you can see on the left hand side, you see the different tumour sites that we're focusing on there, and then you can see the difference between someone diagnosed at stage 1 compared to stage 4, and that's looking at 5-year cancer survival. So you can really see the difference between the two. So the more that we can do to bring someone's stage forward, the better, and that will give people the best opportunity to have more treatment options available to them and to have a greater chance of survival of their cancers. Next slide, please. But it's not all bad news. We've actually made some really good progress over the last decade or more. We've had some introductions of some really positive things that have made a difference to cancer stage. So one of the things, again, I'll be talking a little bit more about that later, but is the lung cancer screening. We're seeing many more lung cancers being diagnosed at stage 1 and 2. We've had the introduction of change of the FIT test that's been brought in that's made a difference to the bowel screening. We have the breast screening, which has given people much more access to better treatments. We have just in general, the early diagnosis we're seeing has massively improved. The early diagnosis rates for all cancers has improved, and that gives people much more access to better treatment options and better outcomes. The smoking rates are continuing to fall, so we've seen a big decrease in the smoking rates, which obviously it's widely known that the impact that smoking has on not just lung cancer but many other cancers as well. So that's all a really positive thing. And we're seeing lots more people attending their screening. So the more we can do to encourage people to attend screening, and I'll talk a bit more about the screening programs in a little bit. Another really positive success story, and you may have seen some headlines recently, but HPV, which is human papillomavirus, is a virus that is the main risk factor for cervical cancer. So there is a vaccination now available. It's been around for quite a few years now for 12 and 13-year-olds. So it's given in schools. We've seen a massive reduction, around 90% reduction in cervical cancer in those vaccinated. So that's really making a difference in terms of reducing cervical cancer deaths. Thousands of pre-cancer have already been avoided. And so in terms of that going forward, we've had, we know that GP practices are really, so it's offered in schools, but GP practices can do a lot to help with sort of catch-up programs and things like that. So we've had some real successes with working with practices around increasing uptake of the HPV vaccination as well. So some really positive work, and we just need to sort of, you know, continue moving on and continue to find ways that we can improve the early diagnosis rates. So I mentioned screening programs. So screening, the positive thing about screening is that we can most likely detect cancers at an early stage. And the reason for that is that screening is essentially taking healthy people and it's looking for signs of the disease. So this is people that haven't had any symptoms and are invited based on their age. So because they haven't experienced any symptoms, they're more likely to be diagnosed with cancers at an early stage. So we have 4 screening programs. So we'll go through each of these individually. And give you some more details on them. So if we move over to the first one. So we have breast screening. So this is for women aged between 50 and 70, and they're invited every 3 years. Basically, the test is a mammogram, which is an X-ray of each breast. And the way it works is it's carried out in either specialist clinics, depending on your area, or there is a mobile breast screening unit that often just sort of rocks up to a Tesco's car park or something, and people are invited sort of in rounds. So your GP practice will be notified of when the breast screening unit will be coming to the area, and that sort of potentially is an opportunity to do some awareness raising in the practice so that, you know, everyone's aware of the importance of taking up their screening. Not everyone's aware, but there is an opt-in. So over 70, there is an opportunity to opt in to that screening and continue having the screening beyond 70 as well. Next slide, please. Cervical screening and HPV. So we've already mentioned HPV, the human papilloma virus. So screening is available. It gets quite complicated with this one in terms of ages and who's eligible. So it used to be that everyone in the 25 to 49 age group were invited every 3 years, and those in the 50 to 64 age group were invited every 5 years. There's been some changes recently where we're in the sort of transition period at the moment, but those now, if the individual has had a negative HPV screening, then they will now be invited every 5 years. If someone had a positive HPV in their previous screening, they will be invited on a yearly recall, and basically that's just the changes have been to make sure that we're sort of targeting the right people. So the ones that the patients that are at kind of higher risk of HPV will be invited more regularly, and the ones that are at lower risk are not sort of having to go through those tests. So that's kind of a reason for the change. So yeah, as you can see, it's a speculum is inserted and sample is taken from the cervix. You can see from the photo there. So that's cervical screening. Obviously, feel free to pop any questions in the chat. I'm sure we've got lots of them as we go. So another one we have is the bowel cancer screening program. So the test that's used for that is a FIT test, or fecal immunochemical test. So it shows you the photo there. So this is for men and women aged between 50 and 74. So basically the way it works is that test is sent in the post to the patient every 2 years. So they have to be registered with a GP practice to actually receive that. And then they do the test at home, and then they send it directly straight back in the post to the screening hub. So I just wanted to highlight that you may recognise this test. This might look similar to a test that you've seen in your GP practices. There is a distinction, there's a slight difference between this screening test and the test that's offered in the GP practices or handed out in the GP practices. So the difference is that this test is for screening program for patients without any symptoms, and the one that is kept in the practice, it's still a fit test, but it's kept in the practice for patients that have had symptoms. And so there are slight differences in the test results of those. So it's really important that we sort of make that distinction between the two. And I know, Pam, you've had some issues in your practice with that, haven't you? Where that's sort of, there's been a bit of a mix up.
Yeah, we did. The wrong fit test got sent to the screening program, so delayed a diagnosis of somebody with symptoms. So we did some training in the surgery just to make everybody aware, because they look exactly the same, so they're very confusing.
Yeah, thanks, Pam. So I've just noticed a question in the chat about how to order a test kit. So we have got the number on the slide, so we'll make sure that that's circulated. It's good to have the number on hand so that if anyone is asking or if anyone has misplaced their kit, then you know they can reorder it. I think there is an email address as well that you can send to. I'll sort of dig that out and see if I can put that in the chat as well. So one of the challenges with the test is that it's actually quite tiny and it's quite fiddly, and I think some people can struggle with it. And there's kind of lots of steps. It's all sort of done at home. It's different to the other screenings in the fact that it's sort of, they've got to sort of do it themselves. So there are lots of resources out there to support patients with it. So there are kind of like easy guides and sort of visual things that they can do. There are animations that you can do to help support patients in completing that test. So yeah, so it's worth being aware of those. So I've just seen in the chat as well, are they checking for the same thing? So you're talking about the two different tests. So yes, essentially they are both looking for blood in the poo. But the differences between the tests is what classes as a positive. So it gets a little bit complicated, but there needs to be sort of more blood for it to be a positive in the screening test than in the symptomatic. So it is important, and that's an important distinction to make, so that if, for example, someone's had a negative screening but they've started experiencing symptoms, it's important that they still go, and it's worth repeating, worth having the other test, the symptomatic test, because the thresholds of referral are slightly different. So yeah, so it is looking for the same thing, and the tests are essentially the same, but the results are slightly different. So if we move on to the next slide. So I've sort of mentioned this already. So the test is looking for blood, obviously. So just to make it clear that if someone completes the test, it won't kind of give them a you have cancer or you don't have cancer. Really, it's just looking for the amount of blood in the sample and whether they need further investigation. So to actually diagnose cancer, they would have to go on and have further investigations. And sometimes we find that people might have a positive fit test, but they don't always go on for their further investigation. So that's another area where it's important to be looking at things like safety netting. So we can sort of cover that a little bit later. So they should have their test results within 2 weeks. So if patients are coming in and asking, oh, I haven't had my results back, then it's that same phone number. So I mentioned that you can contact the bowel screening hub for a new kit, but also if someone hasn't had their results. And I mentioned about the differences between the screening and symptomatic fit as well. Next slide, please. So the lung cancer screening program, it's was still being rolled out. To be honest, it's fairly new, but it's been a game changer really. So this targets people aged 55 to 74. It's slightly different to the other screening tests in that it's a little bit more targeted. So it's targeted at those that are high at risk based on smoking history. So, and it's important to remember that actually the way that people are invited are based on their clinical system, how the smoking history is recorded on their clinical system. So actually, if they haven't got the up-to-date smoking status on the clinical system, then they may miss out on receiving that invite. So actually, I know Tamsin, you've put together some guidance on this about kind of how, if you haven't done it recently, and especially if you haven't had lung cancer screening rolled out in your area just yet, then that's a really worthwhile exercise to kind of make sure that people have got their most up-to-date smoking history on the clinical systems. So essentially, people in that age group with smoking history, and also just to mention, smoking history is only 100 cigarettes in their lifetime. So actually, even if someone sort of smoked for a little bit, it's probably quite easy to reach 100 cigarettes, you know, if it was at university or something like that, you know. So actually, you know, it's important that we get the correct smoking status, even if someone doesn't sort of think that they were a smoker. So yeah, so there's an assessment that happens. So not everyone will be offered a low dose CT, but there's an assessment to look at kind of overall lung health. And then if eligible, then the patient is offered a low dose CT scan. Again, the good thing about this, because these patients are unlikely to be symptomatic at this stage, we are able to pick up many more cancers at an early stage. So this is why it's a real game changer for lung cancer. The good thing about it as well is that everyone at sort of every stage of this process is offered smoking cessation support as well. So that's kind of really embedded in the programme. So even if someone sort of doesn't have a lung cancer or isn't kind of offered the follow-up, then they are still given the smoking cessation. So I think we've got a map just to sort of give an idea of where it is available, but in the next sort of year or two, we will be looking for that full rollout, and it is important that sort of GP practices are on board with this, because it could make a real difference to early diagnosis of lung cancer. So that's just to show the pathway again. So obviously patients are identified based on their smoking history, and then they're sent a letter giving them information about the lung cancer screening, and then they will be invited for a risk sort of a risk assessment, and then those eligible will go on to to have a low dose CT. And then in terms of the output of that, they will either be referred to secondary care for further investigations. It potentially could have a nodule that goes into sort of a surveillance program, or if there's a negative finding, they'll just go into the routine 2-yearly routine screening. Next slide, please. You just wanted to touch on this. So you may get requests from patients to ask about a PSA test. So this is a test that looks for prostate cancer. So you may have heard, I don't know if anyone sort of hears about the kind of the controversies around it. It's kind of one of those widely spoken about things, and I think we can't always even get the kind of experts to agree on this. So there isn't a national screening program for prostate cancer, but we do have the PSA test. So the NICE guidance states that PSA should be offered to men aged 50 who request it. But it's really important that that those that are having the PSA test understand the kind of pros and cons, because what we always have to kind of think about when we're looking at screening programs is to make sure, because these patients are essentially healthy, not experiencing any symptoms, we just need to make sure that the benefits of screening outweigh the negatives. And what we found, and what some of the evidence shows with the PSA testing, is it can detect prostate cancers, but we don't always know which of those prostate cancers may have gone on to caused harm for those patients. So some patients can have a prostate cancer and it not ever affect them and not ever cause them any harm. So potentially, if you're diagnosing a prostate cancer in a patient that has one of those cancers that may not cause any harm, they could end up going through all the treatments and some of the side effects of those treatments, you know, that could actually end up leading to harm. So it's a bit of a sort of way up. So they are doing a lot. There's a big trial at the moment looking at this, and the National Screening Committee are looking at this because there's sort of, you know, we are moving forward with progress on kind of getting this better for patients. But it's just kind of, you know, being aware that it's really important that patients have that conversation with a health professional about the pros and cons of having this PSA test. There are certain people that are more at risk of prostate cancer, so it's worth being aware of that. So those over 50, but those with a family history, and Black men are or at sort of greater risk. So it's, you know, worth bearing in mind. So I know we've sort of done some proactive work in the past targeting those particular groups. So a bit of a complicated one, but I thought we wanted to touch on it in case you get some questions about it. Next slide, please. So we've sort of talked a little bit about early diagnosis, but obviously, ideally, if we can be preventing cancers, then that's even better. So this is a fairly old now, but it's an infographic that was produced by Cancer Research UK, and it highlights some of the ways that cancer could be prevented. Now, it's a really difficult topic to discuss with people, I think, because often people can maybe feel sort of blamed for their cancers, and you know, or there's always exceptions to the rule as well, where someone might have been really healthy and lived a healthy life and have been diagnosed with cancer at an early age. Or the opposite, we get people that, you know, may have been smokers or been unhealthy and lived into their 90s. So we're not saying that this is a kind of foolproof plan. It's sort of looking at it as a way to stack kind of the odds in your favor and to reduce the risk. So we're never going to know whether, you know, this is going to be perfect, but that we do know that evidence does show that patients can reduce their risk of cancers. So there's a few on there. We're just going to touch on a few that we've sort of looked at over the last couple of years as an alliance. If we move on to the next slide. So these are some of the more practical things that you might want to help support patients with. So there's usually quite a lot of awareness campaigns and things kind of going on that help support some of this messaging. We've got some stuff on our primary care toolkit, which I'm sure Tamsin will be sharing as part of this. So yeah, so there are lots of different options. There's we've recently done some work around identification and brief advice for alcohol, so how to have that conversation with patients. There's some just sort of short bite-sized kind of learning that you can do around that. There's also a module for on the NCSET for very brief advice for smoking. And, you know, lots of resources available. We've also tried to pull together kind of what services are available for signposting and things like that. So it's thinking about what's available in your area that you can signpost patients to, and sort of looking at how you might want to have those conversations with how your patients can reduce their risk. I found the other day, and again, I'll sort of dig it out and see if I can share it with you, that Cancer Research UK have just produced some new GP surgery waiting room screen. Sorry, that's the wrong way to the long-winded way of saying it, but the kind of some information that can go on the screens in the GP practices. So that might be worth having a look at as well, because there's some, you know, good things that you can add to there. But yeah, just any awareness raising that you can do, the better, really. So I think that's all from
Thanks, Vicky. Yeah, thank you for that. We're now going to hand over to Pam, who's going to talk about barriers to care and safety netting, starting with barriers to care.
I, as well as working for the Right By You, I'm also a practice nurse 3 days a week. So actually sitting in the surgery right now, and we've just had a complete example of a barrier to care. So I'll share that with you as well. So I think Tamsin sort of covered this at the beginning really a little bit. So at the front desk, face-to-face language barriers are often really difficult when you've got a massive queue going through the door, and also obviously via the phone. And also just that people would use very different words. So, you know, just this morning I've had a conversation about poo, and I've had 3 different words used for that. So just communicating with people and understanding their language as well can sometimes be a barrier to care. Obviously hearing difficulties as well poses quite a problem at the front desk with confidentiality, when people often will shout to think that makes it easier to hear when the people are deaf. We've had a influx of new staff here, so that can sometimes be a barrier because it's lack of knowledge for new staff, and also lack of knowledge for patients as well. We've had a lady this morning who was thinking of declining her offer of radiotherapy because her most important person in her life is her dog, and she couldn't work out how she was going to be able to go for daily radiotherapy for 5 weeks and also be able to look after her dog. So we've got a brilliant member of staff here who knew about rehoming and fostering. So I've learnt that today. So the dog is about to be fostered, hopefully, which will enable this lady to make a decision to go ahead with her treatment for her cancer. And also, I think it is worth knowing what your escalation pathway is in your surgery. So every surgery will be different. And hopefully there is something that you've got in place that if you have got concerns about someone, whether that's a gut feeling that Tamsin alluded to earlier, or whether it's a problem with language at the front desk, or somebody not understanding what you're trying to explain, then hopefully you've got a pathway of what to do next with that concern, so that it sort of hopefully something does get done. Next slide, please. The next slide there, Tamsin. Thank you. So safety netting, it's a word that's used a lot in general practice, and it's sort of what does that mean really, and it's a little bit different I think for clinical and non-clinical. So as a clinician, for myself, then it's a structured approach that we use in primary care. So it's when we're managing somebody when we're uncertain of their diagnosis, so we can then guide patients on warning signs and ensure that they've got a clear understanding of what to do if they are concerned and develop what we often refer to as a red flag. They then understand the expected course of their illness and when to ask for further help. So sometimes, as an example, if I'm looking at a wound and not unsure, it's a Friday afternoon, I can't take a swab, and I'm sure whether it's infected, then it's worth saying to the patient, if over the weekend ABC happens, then please do 1, 2 or 3 of the advice that I'm giving you. And that's what we're referring to as safety netting. You have a absolutely crucial role in implementing safety netting. So it's preventing that falling through the cracks that we often talk about. So if we are arranging, as an example previously that Vicky was talking about the fit testing, then it's following up whether that fit test has been completed by the patient, whether that's we have a code come through from the screening team to say that they didn't engage, or whether it's a fit test that's been given to somebody with symptoms in the surgery at a face-to-face appointment with the GP, that we're following up to make sure that they actually then handed that back in at the front desk. Arranging urgent appointments that we are often asked to do, booking up reviews, checking that referrals are sent and that they're sent on time and also to the correct department. And also, I mean, it sounds really simple, but just double checking that mobile number has not changed, address hasn't changed, and it sounds simple, but they can make a massive difference. Often when we're doing a presentation to the nurses, we use a just quick case study of a lady who contacted the surgery to ask for antibiotics because she thought she had another urine infection, and the receptionist checked with the doctor, antibiotics were issued, and a urine specimen was sent off. And then unfortunately what happened was the urine specimen results were filed, but actually for a specific blood test that they were doing on the urine, that part of the result was not actioned. And so it meant a delay in the lady getting a diagnosis, but mostly because her mobile phone number had changed, and also she'd changed address but not informed the surgery, and it wasn't checked initially. So just simple things that can make a massive difference. So for that lady, she could have been having tests for bladder cancer within 3 weeks, but it was delayed by 4 months because of just some of those things that weren't followed. Thank you. I think the first sentence I've sort of covered. We use a teach back method here, which is quite a simple thing to do when you're talking to anybody. And it's not a test, it's more of a check that the person that you're talking to has understood what you've been saying. So when you have explained something, it's just at the end of it saying, oh, do you just want to recount to me what you feel that you've understood from what I've talked about? And then if they repeat it back and it is then incorrect, you can just clarify that misunderstanding, and just double check that they've actually understood that. So this morning, I did that with a lady who came in for a wound, which was post-operative, and she had no dressing on a fairly big wound. So I explained the importance of needing to keep it covered. And then at the end of the consultation, just very simply sort of said, oh, would you like to sort of just repeat back to me what you're understanding that you're now doing as part of your self-care with the wound? And she repeated it back incorrectly. So it's just a really simple check. And if anybody would like any more information about that, then just email me. Happy to go through that. Thank you.
Thanks, Pam. Back to me now. I'm going to talk just briefly about cancer care coordinators. I think there's some of you on the call now. This is something that came from the original R's roles. I just want to mention the work that they do, and for you, if you're not a cancer care coordinator on the call, do you have one in your practice or in your PCN? Do you know who these people are? We start out quite small, and through the Cancer Alliance, we kind of increased and increased and increased. I do need to update this graphic because this is back to September 2023, but we increased from 13 to 34 in a year. And I think we're probably in the 40s, if not lower 50s now across the patch. There is a community of practice led by my cancer care coordinator at Burgess Road, Emma. We did have one before, but that kind of dropped off by the wayside, and now it's starting back up again. So if you're not part of that community of practice, please let me know and I will pass on your details to Emma. They meet monthly over Teams, and share best practice and lots of different hints and tips. And it's just a really good resource over Teams, on the Teams chat as well, for you to kind of ask advice or help. There are also other colleagues in your practice apart from cancer care coordinators. Each practice has a cancer lead. Each PCN has a clinical and non-clinical cancer champion, provided that they've signed up to our LIS, which I think is pretty much everybody across Wessex. There are also other ARS roles in your PCN, such as social prescribers, mental health nurses, health and wellbeing coaches. All of these people can work together to help you with your cancer patients. And when it all does work together, it works really, really well, and the patient feels very supported. There's lots of other resources. I'm going to do a little whistle-stop tour of all the other things that are available to you. Vicky mentioned earlier the primary care toolkit on Wessex Cancer Alliance website. The links are all on here, so when I share the slides with you, you'll be able to link into it. Lots of different information on this toolkit for all sorts of different roles, training, everything that you could possibly need. There's also Cancer Matters Wessex, lots of other training and useful information on there too. And we've talked about Cancer Research UK, but there's a learning support element of CR UK, which I think is really good for all sorts of different professionals. They do online learning, lots of resources, and something called Talk Cancer, which I think is really good. I've only just discovered it recently myself. And they do free online workshops for individuals, group workshops, lots of different things. And I'm going to attempt to play a video now, so hopefully this is going to work. This is just a short 2-minute video as to what Talk Cancer actually does for practices. So please do go and have a look at this website. The Talk Cancer link is here, and if you want to share the video, by all means do. The link to that video is there as well. I also want to touch briefly on the CR UK Workplace Health Programme that they have. So we often talk about patients and looking after themselves in cancer diagnosis, but there's lots of people that work in our workplaces as well, so we can't forget about them. And so this is a lovely link for cancer awareness in the workplace, which I encourage you and your teams to look at as well. Vicky mentioned earlier the admin and reception guide. This is on the Wessex Cancer Alliance website. It's printable, and you can link all sorts of different examples of prevention and early diagnosis, screening, urgent cancer referrals, all sorts of different things that are contained in the admin and reception guide. And these webinars are kind of like kind of knock on from this to kind of reiterate that training. Now, rounding up, we're almost finished. Key messages from today. I just wanted to talk about highlight that every interaction matters. The kindness of reception staff can influence whether a patient seeks help. We've all said it, good administration prevents delays, making sure telephone numbers, addresses are correct. Excellent communication saves both time and lives, and early diagnosis improves treatment options and survival. And you are a vital part of the cancer care team, even if you don't physically see patients clinically. And finally, a cancer diagnosis doesn't start when the GP sees the patient. It often starts with the first phone call to the practice. Every receptionist and administrator has the opportunity to make that journey quicker, safer, and more compassionate. And again, these are the webinar series that we have going on till April next year. And please do sign up if you haven't already done so. Any questions? I feel like that time whipped past then. Any questions that you have? I know you've been putting some in the chat.
I've just added those animations to the chat that I was mentioning for the GP waiting room screens. And Alice has also mentioned that the lung cancer screening also detected a kidney cancer, so it's not just exclusive to lung. So it has other
there's quite a few
benefits as
incidentals
well,
that they find that they send to practices. Any questions on screening? Is there any kind of actions that you will the slide should be emailed? Yes, it will. Yeah, they're all going to be recorded, Debbie, and they're all going to be on the Wessex Cancer Academy, which is the training arm of Wessex Cancer Alliance website. So today's will be on there ASAP, and I'll email the slideshow to everybody after each one. Julie, if you look on the website, all of the webinars will be on there. So if you just make a note of all the dates of them, then you can just go onto Wessex Cancer Academy through Wessex Cancer Alliance website. And I'm pretty sure after all of them are finished, I'll send like links to all of the webinars to everybody, to anyone and everyone really, that I can. So yeah, and if you do actually want them, just by all means contact me. I'll be happy to send them out or send you a link to where you can find them. Any other questions? Is there anything you think you're going to do in practice that you might want to take back straight away? Any hints and tips? I think a couple of the quick wins are ethnicity and smoking status for practices. There's AccuRx texts that you can send out. You can bulk text people, little flories, questionnaires, and it'll code straight back into the clinical system. So you don't really have to do any work from that point on, but it'll update people's ethnicity and their smoking status, which, as we know, helps with screening. Thank you, Julie. Yeah, by all means, please do share it with your receptionists. I know they don't often have a lot of time, and you know, sometimes they can be thin on the ground on the front desk. So sparing somebody to come to training is always a bit of an ask. So I know you have target training afternoons. So by all means, get them to sit down and watch the webinars, because it's always great to have other training that they can do. And you can just put it on, and then several of them can watch it in one go, which is great. Yeah. If no one's got any other questions, I'm happy to stop the recording and call it a day.